And as I get started, first of all, I just wanted to say thank you so much for the invitation to speak. Looking at the topics here, I think this seems like a fantastic conference, and I'm very honored to be here right now. So what we're going to talk about today, though, is how we started to use artificial intelligence at UCSD to help us improve outcomes of patients with sepsis. In terms of disclosures, I am funded from the National Institutes of Health, as well as gotten funding from the National Foundation of Emergency Medicine within the past year. And the work that I've been funded to do is what we're going to be talking about, but I do not have any other conflicts. And really, there's two major things that I want to talk about. And they're intertwined, but I think it makes for a good story here. The first is we're going to talk about our experience at UCSD with the development and implementation of a deep learning model to predict sepsis in our emergency departments. And then what we're going to do is talk about how that implementation improved patient-centered outcomes, specifically focusing on mortality, because I think that is something that's quite important as we see more and more AI applications in healthcare. But what I'd like to start with talking about this is the story of sepsis at the University of California in San Diego. And I imagine that everyone here at some stage has taken care of a sepsis patient. And at least what we saw in UC San Diego when I started taking over our hospital sepsis program was that our observed to expected mortality was higher than we would like to see. And the question is, how can we go about in a thoughtful manner of improving patient-centered outcomes to make sure we're giving the best care to patients and to minimize any kind of unintended consequences that could be going on. And in that framework, I started talking with a number of people about how we could potentially expand into the artificial intelligence domain to improve patient care. Now, I think I just want to highlight a few things that when we talk about sepsis and artificial intelligence, there's probably two major branches that people focus on. Within machine learning, there's supervised learning, and I think probably the group here has a pretty good understanding of this, but just to make sure we're all speaking the same language, a lot of times what the models that are out there fall under the domain of supervised learning, where the model is trained both on input features that it knows and output features also that are labeled. And this becomes very, very useful to identify or classify patients at risk of sepsis. And there's been a lot of emphasis on the early prediction of sepsis, and that's where we focused our work on. There's also been some work in sepsis using unsupervised learning techniques where we basically give the model a decent amount of input features and we let it kind of sort it out. And that is an example of something that people like Chris Seymour have put out, where they've developed clusters or phenotypes to try to see how these phenotypes respond differently to therapies. And that's a little bit more difficult. And what we chose to do was to really kind of focus on supervised learning models to, again, focus on that early identification of sepsis patients because we thought that that was an unmet need that we struggled with. Now, just some examples of some of the literature out there that I think illustrates this before we jump into what we did at UCSD. What you'll see here is a picture of the left of one of the first and probably one of the biggest publications that was put out on a supervised learning model to predict sepsis within the intensive care unit. This was put out in 2018 in Critical Care Medicine. A few names to take a look at. Tim Buckman is the outgoing editor-in-chief of that journal. And also Shamim Namati is one of my personal mentors who developed this at Emory. And you can see here, this is what got people very, very excited years ago, was using about 30,000 patients at Emory University in Atlanta. They were able to show a good sensitivity and specificity of predicting sepsis within the ICU about 4 to 12 hours prior to presentation. The classic paper looking at unsupervised learning comes from Chris Seymour, where again, they developed these 4 phenotypes using a clustering algorithm that really kind of built in and tried to identify how specific therapies within sepsis could improve patient care. Both of these were retrospective. And indeed, what we kind of, just to dive in a little bit more to the one led by Dr. Namati, since this was actually the first version that we experimented with at UCSD, is that this actually did get a lot of excitement because sepsis can be a very, very difficult condition to pick up when it's not obvious. And indeed, that's what we saw in our emergency departments is we did very, very well with patients where sepsis was present at triage. These are the patients that had high fevers, high heart rates, low blood pressure. We don't need any help with that. But for the patients where there's diagnostic uncertainty and it's difficult to pick them up, we really felt that identifying them through use of a deep learning model could be quite useful. So just to summarize what they did at Emory, and again, this is what the model that we used as the basis for what we use at UCSD, is they took a look at about 28,000 patients within Emory ICUs. They had 65 input features, largely data points that were available in the electronic medical record, things like vital signs, demographics, medications that had been administered. And what they wanted to do was to predict sepsis 4 to 12 hours prior to the development of the actual condition. Now, this is something, if you look at this event horizon of 4 to 12 hours, I think is actually quite useful because it gives the providers an actionable time to do something, but it's not too immediate. And it also gives you that urgency because if it's 24, 48 hours down the road, there's a decent chance that someone might not be working in the hospital when that concern for sepsis will be there. So it minimizes the utility. So I think they did a very good job with, at that point, selecting this 4 to 12 hours ahead of onset. And again, this is just a basic model kind of showing what they did here. Again, their model performed very, very well at that point with data, in 2018 showing with a fixed sensitivity of 0.85. The AUC was very, very close to that also at 0.85, 0.86 in the training and testing data sets respectively. So again, a very big win when it comes to the actual model development about what could be done in the retrospective fashion. Now, obviously, the concerns with this, and I don't know if they're concerns, but rather some of the key takeaways. First of all, this was retrospective and it was observational. And this is something that I've seen with a lot of sepsis predictive scores is that it's very easy to develop a model, but a lot of the challenges now become implementing this, bringing it to the bedside, and seeing how this improves patient-centered outcomes. Now, of course, people got excited, right? This was one of the first times in a prominent journal that people were able to show this, some kind of machine learning model could predict sepsis ahead of time. One thing also that I think is very important to mention is that for the cases where the machine learning algorithm said that the patient was at risk of developing sepsis and the patient didn't develop sepsis, is something else was going on with the patient at that point. For example, if the model said this person is at risk of developing sepsis and they didn't develop sepsis, a lot of times in the development, when those cases were reviewed, the patient either had a heart attack or a gastrointestinal hemorrhage, something else that needed the providers to evaluate to kind of see what was going on. But again, the key point here is the implementation and the generalizability were unaddressed. And we were actually fortunate to steal Dr. Namati from Emory University to bring him to UCSD in 2018, which is when I started working with him. Now, of course, when talking about any kind of sepsis predictive model, I think one thing that is worth highlighting is that if the implementation is not great and the model is not externally validated at the site that you work at, the outcomes might not be as good as you were hoping for. And I think perhaps one of the biggest precautionary tales of a predictive model that has been used widespread in the United States is that of the EPIC sepsis score. And again, the model performed very, very well in retrospective fashion. But this is Dr. Kirandeep Singh, who is now a chief AI officer. But he was one of the first to actually go through and rigorously evaluate how the EPIC sepsis score did at the University of Michigan. And it's quite interesting if you take a look to see how the EPIC sepsis model did, it underperformed based on what people were told about how the model actually should do. And some of the key metrics to be aware of is that the EPIC sepsis model reported an AUC of about 0.75 to 0.8. You can see at Michigan, though, the AUC significantly dropped to 0.63. So not much better than a coin flip. Of the roughly 2,500 patients with sepsis, the EPIC sepsis model didn't identify about 1,700 of them, which is inherently problematic if that many are being missed. And something else that I think is also very, very important when we talk about these alerts that are generated for patients is that about roughly 7,000 patients had some kind of notification that was generated. And again, you can see of those that were actually predicted or appropriately picked up on, about the 800 or so. That's a lot of alerts for very few patients that the model appropriately identified as being at risk for sepsis. So it certainly does make it very, very difficult, and it highlights some of the challenges when it comes to using a sepsis predictive model. So what are some of the key takeaways from Dr. Singh? Well, this was a little bit of a shock, I think, to a lot of us that were following around thinking that when we implemented the EPIC sepsis model that we were using this and would have great outcomes. And I think perhaps the biggest one is to make sure that the model that is being used is validated on the site where it is being used by providers to potentially improve patient-centered care. And I think that's unfortunately for EPIC, who's done many, many wonderful things with their electronic health record. This was a little bit of a black eye, and it got a lot of press in the media about why was this happening. And again, I think a lot of credit to Dr. Singh for highlighting that the external validation and the implementation is of utmost importance when it comes to using any of these models. And that brings me to one of the important things is we've been, experimenting with bringing some of these models to the bedside at UCSD, is that oftentimes a lot of clinicians are unfamiliar with the approaches that we're using, and they become inherently mistrustful because of high false alarm rates, like we saw that Dr. Singh reported at the University of Michigan. Workflow interruption is also something that is very, very important to be aware of. I think at least what I see with the people I work with in the ICUs and the emergency departments is the immediate response to some kind of notification on Epic, which is what we use, is to see how people can get out of it as fast as they possibly can. And there's also concerns sometimes that people say, well, these are black box models. They don't really tell us why they're firing. It's just popping up there, and I don't trust that. And importantly, one thing that we've seen when we did a wide survey with providers was that oftentimes, particularly critical care doctors, but many other doctors, feel that there's not enough high quality evidence to support the use of machine learning models in clinical care at this point. So this is something that we put out last year in critical care medicine about some strategies to improve the utility of machine learning models. And everything that we put here, we were largely focusing on at UCSD when it came to our own sepsis predictive model that was based on Dr. Nemati's. One of the things that we felt strongly about was data augmentation, namely that we're not just using lab results, vital signs, and medications within the electronic health record, but seeing how you can reach outside of that to bring additional data in to help with predictions. This can be something as fancy as wearable devices, but what we've also experimented with is using a large language model to bring more data in. Obviously, generalizability of the model is something that's very important. We've taken some steps of showing that transfer learning can be quite effective to bring a model from one institution to a completely different one and maintain very good test performance of the model. Implementation science is something that's paramount, at least for a lot of my training right now. What I focused on is how to make sure people react well to the model so they actually get some of the benefit of it. And I think something that's a common theme now when it comes to any kind of artificial intelligence or machine learning conference is we certainly do need to see the data about how on prospective studies to assess the actual benefit rather than talking about the model that we built that hasn't been implemented. And unfortunately, we don't have enough time to talk about governance. That's, I think, a totally separate topic. But anyway, so here are some of the strategies that we took for our model about improving acceptance based on some of the concerns that we identified from providers. And I think everyone would agree here that a false positive from any kind of predictive model is inherently problematic. It loses trust in the end user, and oftentimes people don't want to use the model after they've seen a number of false positives. And what we hypothesized, what we thought, is that there's a decent amount of outliers when it comes to sepsis, to patients with sepsis, that the model just didn't recognize what was going on and it would make a bad prediction regardless. Now, this is the work that we put on this, and I'll show you how it works very shortly, but we put it out in Nature Digital Medicine 3 years ago. And effectively, what we were looking at is using something called conformal prediction. And what that refers to is that as we were building the model for this, we wanted to make sure that we had a good understanding of what the model understood was sepsis. And we put that into what we call the septic conformal set. And then if a new patient encounter came in and the data just did not fall with anything that it had ever seen before, the model effectively said, I don't know, and did not put out a prediction. In effect, rejecting that patient encounter, so we wouldn't give a false positive or potentially a false negative. And if you're curious how this did, here's some of the AUC as well as the false alarms per patient per hour, what we see here. And the model that we built is going to be in the upper right-hand corner right here. Epic is another one of the models that we did use here. I'm not going to say which one it is, but we were able to show that the AUC significantly increased from other approaches in terms of machine learning models to predict sepsis. But importantly, what we were very excited about is the false alarms per patient per hour with the model that we use, which is called Composer now, significantly decreased compared to the other models. And again, it goes to something that increases the believability of what we are actually telling, when these alerts go off and our nurses and doctors interact with them. Something else that we've brought in very, very recently is unstructured data from clinical notes. And this kind of shows a brief approach of how data goes from our electronic health record. It's then abstracted on an hourly basis, goes up to Amazon Web Services. We run our prediction, and then we ingest the clinical notes that are available at that time. And we ask using a large language model, we ask the model, based on the available clinical notes there, is sepsis a possibility? And if the model says no, then we suppress the alert that goes out to the providers. And again, the goal here is to decrease the false positives. And this is under review right now, but what we were able to show is that the positive predictive value of our model went from about 25 to 30% up to about 40% or so. So a very significant increase in the positive predictive value that for sepsis models is very, very high, just given some of the challenges with that. So here's what we did at UCSD, and I'll break this down in terms of, the different steps. So what we wanted to test using a mature deep learning model that we were ready to implement was that the algorithm would be feasible to implement in real time and would help guide clinicians to identify sepsis earlier, which would result in improved patient-centered outcomes. We just published this piece. It was put out in Nature Digital Medicine, I want to say about 8 or 9 months ago, so it's relatively fresh. But I think the findings are pretty compelling. And specifically what we did is, like I mentioned, we took the model that Dr. Namati developed at Emory, and published in 2018. We made changes, including that conformal prediction, and more recently using the large language model. We also adopted an implementation strategy after talking with some of our implementation scientists at UCSD about what they thought would be a great strategy, and we'll talk about that one a little bit more. We had a very broad interdisciplinary team, including the chief administrators of the hospital were on board with this. Department leadership was on board with this. Nursing leaders were on board with this. The bedside nurses, the bedside physicians, everyone agreed that this is something we thought was worth pursuing. And then we brought the model to the bedside and we studied how it impacted outcomes. And again, just to show you what we did, right? This is, some of the key points, I think. Right now, we take a look at 150 input features into our deep learning model to predict sepsis. Data is transmitted on an hourly basis up to Amazon Web Services, and then it comes back. And what we focused on a lot of, too, is the appropriate suppression logic. Namely, this is to make sure that the alert does not fire and create annoyance to the physicians and the nurses that are receiving this. So some of the key things that we've made sure to suppress the model for is if the treatment team has already identified that the patient is septic by sending blood cultures and starting antibiotics, it adds zero value to the care if we say, hey, consider sepsis in this patient in the next 4 to 6 hours. So we suppress that alert to make sure that people are not annoyed by this, because that was one of the big concerns that we had. And that was also highlighted by a lot of the nurses and doctors that we work with. The implementation framework we went with was called EPIS. EPIS stands for exploration, preparation, implementation, and sustainment. And this is something that even though we went live in 2022, we started working on a lot of the behind the scenes parts in 2020, particularly the exploration about the ideal population would be targeting, as well as the preparation to make sure that we had the appropriate support to do this. The implementation felt honestly like it was one of the easier parts after having a significant amount of time in the exploration and preparation phase. And what I actually find right now is the most challenging part is the sustainment phase, because we've seen a lot of our nurses and doctors that we train to use this have left and gone elsewhere. So the study design when we published this was a pre-post quasi-experimental study in the emergency departments at UC San Diego Health. We wanted to do a randomized trial, but that was exceedingly difficult. And we felt that kind of seeing how we did before and after would be a good approximation. We had about 6,000 or so patients with sepsis during the study time period. And we selected actually our nurses were the ones that would receive the best practice advisory. And we went with our nurses for multiple reasons. One is that they tended to have more interaction with our patients, and their instance of EPIC was open much more for the specific patient than our nurses. I also got the feeling that our nurses were a little bit more excited about using this and would probably be a little bit more responsive. And then what we used to assess the impact on of our best practice advisory with the prediction of sepsis was a causal impact analysis that was done with the Bayesian time structure series to really kind of get at what the expected versus observed mortality was going to be in these patients. And we went big with our primary outcome. We wanted to see how this impacted survival, but also took a look at other components that we thought would be good secondary outcomes, like bundle compliance, making sure antibiotics were started, looking at organ failure at 72 hours. If you're curious, this is the best practice advisory that we developed at UC San Diego Health. You can see a few things. This was actually the first one where we were able to put in a best practice advisory to put a secure chat. My name was put here because I wanted to know about all instances when this was going on. And then we also really limited the reasons that our nurses could respond to this. Because in the past with some prior models, we've noted that people would try to get out of these as quick as possible. So we really limited it. So how did our BPA do? Well, we didn't fire too much. On average, in the post-implementation phase, it fired about 235 times a month. This works out to about 1.65 alerts per nurse per month, so not overbearing. Importantly, what made me very excited is that the nurses actually took this seriously. And they actually, if you take a look here, you can see over 50% of nurses for each alert they got would make sure that that they would notify the physician immediately. And what I was worried about, the dreaded, I'm going to ignore this alert, was a very, very small number of cases as patients or as our nurses leaving the best practice advisory. So something that we were very, very happy with. Now, in terms of the major outcome that we found, we saw about a 17% in the relative decrease of sepsis mortality, which corresponded to about a 1.9% absolute decrease in sepsis mortality, which we were very, very excited about. And just to put that in terms of, numbers of patients' lives saved per month, it turns out to be close to 5 lives per month in the implementation phase that after we went live with this. We also saw that there was an increase in our sepsis bundle compliance. This is something that we have to unfortunately report to a big regulatory agency within the United States. So we were happy to see about a 6% absolute increase in our bundle compliance, which we were excited about too. And it also provides, I think, a mechanism about how this could improve, about if we are completing more bundles, that might explain the increase in survival. We also did see a decrease in time to antibiotics when nurses alerted physicians, another potential mechanism about why this might work. And then we also saw that the severity of organ injury 3 days after the patients had the alert was lower in the group that in the intervention phase. So again, another potential mechanism that they're not as sick in the 3 days after they were treated in the emergency department and the alert went off. We then assessed our nurses, our doctors about how they felt about this. And we found that about 80% of nurses and doctors felt the tool was either useful or had a neutral feeling about it. Our nurses tended to see there was more benefit. And when we broke it down by kind of age of the provider and nurse about who felt they got the most benefit, it seemed like it was the younger generations were those that actually received more, were more excited about the best practice advisory and the use of this, there's probably multiple reasons why that occurs, but we did not probe any further there. So here are the conclusions from this talk. So first of all, I do think sepsis remains a public health emergency, and using artificial intelligence to help providers identify cases, I think there's certainly a strong case for it. We saw how Epic's model did not perform as well, and that really making sure there's an appropriate use, external validation of the model before use, and implementation becomes absolutely critical. And I still think one of the unmet needs in this area that we're very, very interested in pursuing are prospective randomized trials to really kind of get to the bottom of how beneficial these models are. And just to close the story about how we started at UCSD with our sepsis mortality, you can see actually after we went live with our model, we had the best mortality that we've had yet. So it is something that's been very, very excited to kind of watch over the years.